challenge is going to be to start to set up your maxillary anterior teeth. Those people that identify the fact that they're struggling with the maxillary anterior teeth, don't be afraid. Identify yourself to me, and we'll get somebody to help you. We do have some sophomores that have already shown, and they're just starting, that have already shown that they're ahead of the curve, and they'd be willing to sit with you. In the beginning, I kind of I struggled a little bit, but then I started to realize that, hey, you know what? This is fun, and I did it. Today you're going to learn how to do it, and today you're going to see that we're going to make these trays. You made these custom trays, right? We talked about this, and I don't want to sound like a a broken record. I guess it would be a broken CD. What do you call it? What? No, broken MP3 player. What is it? I don't know what the young people use, but I don't want to keep saying the same thing over and over and over again. But you made these trays. You made these custom trays where you use a wax relief, right? You use the wax relief in order to get a little bit of space between the tissue and the tray, so that when you took your impression, you had an even amount of impression material throughout your tray in order to get the maximum amount of accuracy of the mucosa. Okay, we're going way back, long time ago. Lecture 1. Okay, lecture 1. Sounds like a year ago or so or more, just a few weeks ago, but we started talking in the beginning. And after seeing how well you guys did on this exam, I'm very happy to say that you've actually moved forward in the profession, because now you have some groundwork. You have these landmarks that we can now talk about, and we're going to start kind of throwing these landmarks around. You learned about the frenum and the fact that the frenums have to be relieved, because if you don't relieve them, you impinge on them, and when the patient moves their cheek and they are impinged on by that appliance that you made, by that denture that you made, that they're going to get sore spots. So there's areas that you're going to have to relieve. So we're going to go back to this custom tray idea. We're going to go back to this custom tray process that you did where you put the wax relief on. And this time we're going to make a tray with no wax relief. This time we're going to make a tray on a model that was poured from the impression that you just took last week, or in some of us 15 minutes ago. We were rushing to get finished, and we will finish the impressions today before we go home. The final impression is going to generate a master model. That master model is the model that you're going to use to actually make your denture. The master model is what you're actually going to use to make your denture. What I want you to think about this time, when you get your master model, that master model is a negative imprint of what your denture is going to be made of. In other words, that master model represents exactly the interior surface of the denture. It's going to be made directly on all the little grooves and fissures that are in that model are going to be on the inside of the denture. So now we have the liberty now, since we know where our extensions are. We started talking about the length of our denture and where our denture extends to. Now that we know where it extends to, we can make a tray that goes all the way in the vestibule that's actually exactly the fit. Once we take it off of that model, it fits directly into the patient's mouth. So we have ourselves a mini tray that's extremely accurate. We had this tray, we put in a relief of a layer of wax, so that when we took the impression, we actually border molded it just to make sure that we got the exact borders and the exact position. And then we took this impression. I don't know if I told you that. I don't know if I told you that. We call that impression that we take inside of that border molded custom tray. Did I tell you the word? Did I tell you the slang word? Did I? I must not have. Yeah. Well, you're old enough now, I can let you know. A wash. They must say that in Canada. A wash. A wash is what it's like jargon. It's like cool talk. The wash is what we do. What we're doing is we're taking a fluid type of impression material and we're letting that take the space of the waxed shim that we put in. And that now is giving us a very accurate impression of that patient's mucosa. Well, we have it now. Well, you're going to have it soon. You're going to be getting it for those that are turning their impressions in. You're going to be getting it next session. You're going to be getting that master model. And on that master model, you're going to make this tray. And this kind of tray now is not going to have any wax shim under it. This kind of tray, this type of tray that you're going to make is going to be made directly on your master model. Why is it made on your master model? The reason it's made on your master model is because we're going to take that tray now and we're going to put it inside of the patient's mouth. And when it goes in the patient's mouth, it should fit perfectly. It should fit perfectly because we've taken our time, bordered, molded our shortened custom tray, did a wash, and now have this beautiful stone model that's an exact replica of what's in your patient's mouth. So what's beautiful? Going back to lecture 1, going back to the first day that we met, what did we say? We said that we have a patient who has no teeth, has nothing for us to go on, no landmarks for us to hold on to because they have no teeth. You know, dentists use teeth as reference points. Dentists use teeth in order to make something stable. When a patient has a few teeth in their mouth, we can go to those few teeth and say, hey, you know, you guys were in the same position last time I was here. I think I'm going to use you to establish where I am. But now we don't have that because your patient has no teeth. But what we do now have is a tray that fits the mucosa exactly the way that mucosa sits because we took the time to the shortened tray and border mold it and actually take our wash. Is anybody unclear so far? We got a tray because we've got to build on this, and we're going to start. I just want to establish this as our foundation. Our foundation is this tray, and this tray is something that we're going to start to set teeth on. Okay? Just a little bit of terminology. Okay, just a little bit of terminology. Do I have to memorize this, doctor? Yes. Yes. The tray is called a base plate. Okay, we're going to call it a base plate. Okay, so whenever we talk about trays now, we're going to start using the terminology that you use when you talk about this stuff. And so we're going to have a base plate, and that base plate actually sits on the cast. Okay, so we're not going to say tray anymore, or we're going to say the words interchangeably. On top of this base plate, what we're going to do is we're going to build up a wax rim. And on that wax rim, we're going to build that wax rim so that we now have the ability to have two things, a maxillary base plate and a mandibular base plate that sit in the patient's mouth. And by the use of having wax, we can actually determine how wide the patient's mouth is to open, where the patient's mouth is at rest. We now have something that we can use that's going to sort of tell us about the dimensions of that patient's maxillary and mandibular jaw. We can also use it with wax. We can use wax now also to set teeth. Now, denture teeth are made of different kinds of things, and I'm going to give you an opportunity to have Dr. Freeman. I'm going to come to you maybe next week to go over the different kinds of teeth. But we have acrylic teeth and we have denture teeth that are made of porcelain. We're going to be using acrylic teeth, and there's a good reason why we use acrylic teeth. So, Doug, yeah, please. Oh yeah, can we do the clicker maneuver? I don't know if the rule is that you may lose up to 2 points or something. There's a point value. There's a point. Yes?
Could, just in the future, anytime we have to click in while we're in the lab, can there be an announcement made? I know a lot of people are working and then the attendance opens, nobody knows. So just if we have to click in, someone on the line.
Does anybody disagree with that? I mean, that sounded reasonable. Does anybody say no to that? All of a sudden, people started talking like they were anti-taking an announcement. Of course. Yeah, please. My goodness. You should be happy that he mentioned it. Yes, sir. Clapping is reserved only for me. All right? Yes. Sorry. Question, sir. Okay, then he must be ready to click. All right, are we ready, Doc? Dr. Farker says you can click now. Okay, but without a doubt. Please understand, my intentions are not to try to click to hold you to the fire. My intention is that if you're not in lab and you're struggling, then I need to find you. Because if you're struggling in the beginning with the anteriors, it's going to be almost impossible to catch up with the posteriors. So it's like, this is all for you. It may seem like it's punitive, but it's not punitive at all. It's just that this is frustrating sometimes, but once you get it, you get it. So we're going to use these record bases in order to put teeth, shift teeth around, make teeth so that they look good on our patients. So here we go. Our base plate is a plate made of photoactivated polymer, which is well adapted over the edentulous surfaces of a definitive cast. That cast that you get is going to be your final cast, and this record base is going to be something you're going to be making directly on that cast. Okay, we got it? So now we can take this and put this in the patient's mouth. Now this is the wax rim that I was talking about. This wax rim is something that first you're going to have this base plate that you're going to actually place on that cast that you're going to receive next week, and you're going to put a wax rim on top of that base plate. Now, this is your base plate, and believe it or not, you're going to get pretty good at making this because we're going to have a, what do you call it? Practical, that was the word. Yeah. Practical on this, okay? So you're going to learn how to make this. If you notice, this one's a little bit different than the one you made when you made your custom tray. When you made your custom tray, you had a little wax shim that's in there, okay? And that shim had those little 4 rectangles on it. And I just missed. I wanted to put it on the on the quiz, and I forgot it. You guys just lucked out. What are those little square, rectangular points that are in the shim? What are they called? Shoes. Socks. All right. Oh, you guys know that stuff. All right, this is a shame. Making fun of the teacher. All right, here you go. Right here. If you look at this area right here, on your cast, I want you to realize now, you've got a cast that's absolutely identical to what the mucosa looks like in your patient. In your cast, you're going to have what's called an undercut. Okay? There's certain terms that I love to talk to freshmen because I know that many of you are going to be hearing this for the rest of your lives, and I'm the first one to be able to tell you. Okay? So here, get used to this, ladies and gentlemen. Those of you that intend on being general dentists, get used to this word because you get ready to hear it a whole lot, especially like next year when you go into fixed with Dr. Goldfinger, when he comes in and he starts making you do preparations, you're going to hear about this thing called undercuts. Because now your mind is no longer going to be static, but when you do things in this profession, you're going to start thinking about these things in motion. It's not just a matter of what you make that counts. It's the fact that you make it so that a patient can bite with it, so that a patient can chew with it, so that the patient can take it in and out of their mouth. Understand what an undercut is. An undercut is an area that when a person is taking, say, a denture in and out of their mouth, okay, it sometimes has to go under a ridge. That's the best way to describe it right now. An undercut, when you start to think about the fact that this is upside down, okay, in case you didn't know, okay, this is upside down, but if a patient had an upper denture and was taking that upper denture out, if this sits out, when the patient pulls that denture out, they have to go over that bulge. Sometimes when you're making a record base, you don't want to trap in that undercut, so we'll take wax and we'll melt some wax in there before we make our base plate. And so when you have a severe undercut, it's a good idea to do that. You may not see it on this master cast that you have, but when you start seeing patients in the clinic, you need to be aware of this slide. When you have a massive undercut, you block it out with wax, and then you proceed on to make your wax rim. This is something that you're just going to have to kind of like memorize, okay, in order to get to the next step, okay? There's just no way around it. These are the dimensions that you're going to do, bless you, when you do that maxillary rim, which is going to be on a practical that you're going to have, okay? The wax rim is made on the maxillary denture base plate and the mandibular, so you have two wax rims. The wax rims have a dimension, and that dimension is when you look at the labial flange. See, I love it. Now we can talk words now because you understand. The labial flange in the front, this is somewhere between 18, and I like to say 20. Some people say 16 to 18. On ours, it's usually about 20 to 20 millimeters long from the longest part on the flange to the very occlusal table. So I'm sneaking in a quick new word for you just to keep those people awake. The occlusal table. Bless you, the occlusal table. That's what we're going to be working on from now on. The occlusal table is the table with which we're going to use to actually set denture teeth. In the anterior region, we have 20 to 22 millimeters from the height of the highest part of the flange to the occlusal table. This area here is a flat table, this horseshoe shape that's across the alveolus. When we start to think about the thickness of that occlusal rim, on the very anterior portion, that rim is 3 to 5 millimeters. On the middle portion and the premolar area, it's 5 to 7, and in the posterior area, it's 8 to 10. So these are just numbers that you gotta kind of remember, especially with this class, okay, when you're making this rim. Okay, if you were to take does everybody know that in their wax setup, wax tools, what you're using for wax up, there's this little caliper. It's like a millimeter ruler with a little points on it. Okay, got that? I don't think you guys ever used that, did you? Haven't used it yet, huh? I know, because I've seen. I love when I pick one up and it's like brand new. No one's ever used it. I use it for the first time. Well, you're going to have to take them out because you're going to need them for this part of the class, okay? So don't let me see them being brand new again because you're going to need them. Those things right there, what you use that for, right in here, you can measure with that caliber that you're somewhere about 8 millimeters from the inside of your base plate to the edge of your maxillary rim in the posterior area. What's that going to do? What that's going to do is it's going to give you a plane of occlusion where the anterior part is slightly longer than the posterior part. You're going from 22 to 18. So that sort of represents the Did I go over the allotragus line yet? Yeah? Okay. All right, we will in a few seconds. That represents a line that we're going to be talking about shortly. Going back to your base plate, this is a lower now. Okay, we're simply going to take this this photosensitive acrylic, right, and we're going to mold it like we did with our custom tray with no shim, okay, directly on top of the cast. And now we're going to trim it just like we had to trim our custom tray material. We're going to trim it, and then that's going to be the base plate made of resin. Okay? This now is the dimensions of the lower rim. The lower rim, 3 to 5 anterior, 5 to 7 in the middle, 8 to 10 in the posterior. Okay? You can read this at your leisure, or you can memorize it whenever you have nothing better to do. And the anterior area of the lower rim is 15 to 18 millimeters. Okay. Just a few seconds before half the class falls asleep. I got to get this in before I lose you, okay? Because this is like the best part. And I waited all day. And this is the part I've been wanting to tell you, because you got to get it, and you got to get it right now, okay? That is that the height of your teeth, forever and ever, the height of your molar teeth is in a plane that's 1/2 to 2/3 the height of the retromolar pad. The plane of occlusion on the mandible is 1/2, or on a line that's 1/2 to 2/3 up the retromolar pad. Okay, it's like the Holy Grail. It's like, it's utopia for this class. 1/2 to 2/3 up the retromolar pad, sir? No, I can't. I got to say it fast. 1/2 to 2, I just love it the way it rolls off, but I'll say it slow for you. It's, okay, you know what the retromolar pad is? Okay, so the plane of occlusion that you're going to set your teeth, and you know what, you could write this down every way to Sunday, but I'm going to say it so many times that you'll fall asleep saying it's 1/2 to 2/3 of retromolar pad. I wish he'd shut up. He's in my ears. I can't go to sleep unless I hear 1/2 to 2/3 of the retromolar pad. So is that slow enough? I could say it backwards. 1/2 to 2/3 up the retromolar pad. Well, you guys forget it. So what that is saying is that when you look at your tray, the base plate, that this plane of occlusion here is 1/2 to 2/3 the retromolar pad. Why is that so extremely important? Why is that so extremely important in dentures? Because some of the mistakes that we make in dentures is that the actual mandible starts to curve upward as you go distally. We don't want teeth set up in a slant. Mandibular teeth are set in a flat plane so that when a patient bites, they're biting straight up and down. Okay, so we want teeth to be in a flat plane. And where's that flat plane going to be? 1/2 to 2/3 of the retromolar pad. Now, so that is our benchmark. When we start to talk about the plane of occlusion, that's where we're going to start. We're going to start about something a little different in the anterior region, but in the anterior region, just to start, we're looking at somewhere, I guess, is about 15 to 18 millimeters anteriorly, and this looks like it's about midway up that labial frenum. Okay, so this is where all of this anatomy stuff is starting to come in, because we're using our anatomy now to sort of dictate the places that we're building our teeth. So here we go again. About 18 millimeters anteriorly and halfway to 2/3 up the retromolar pad. This is a really good one, okay? This is a really good one because when I'm going to show you in the laboratory, we're going to draw a line on the land area. Did I ever use that word? I guess I never did. Okay, the land area. We remember when you took the impression of your model, you had that flat area around the border. That flat area around the border is called the land area. That land area is where you're going to put little markings, so it's going to identify exactly where you're going to set your teeth. Okay? In your packet, you got also a white ruler and a clear ruler, and the clear ruler had a little arc on it. Has anybody? I know. It's one of those things. I like it when I take out the first one. You have it. You just haven't put your hands on it. Get your fingerprints on it. You're going to really need it, okay? That ruler is going to be what's going to really help you set teeth. We'll go over it. No big deal. It's in the lab. 18 millimeters anteriorly. And look at this. Look at this. Look at this. 15-degree pitch. 15-degree pitch. Lower teeth, they kind of like move out. They're tilted forward. Not exaggeratedly, but they tip forward 15 degrees. We had this discussion a few months ago about the articulator, and I think you guys kind of got it. I mean, it was the first day that you went in the you remember when you used the articulator? I remember it was the first day that the wet lab got destroyed. Yeah, you guys have to, yeah, that was unbelievable chaos, is right. Yeah, it was just, you know. Anyway, but if you remember, we're just going to go over this real quickly, because what we're going to do with these wax rims, we're going to use these wax rims to take the information of your patient's occlusion to this machine called the articulator. Okay, so and the articulator is what we're going to use to simulate the patient's jaw movement. But mind you, it's not the last thing in the world. It's no longer really the standard. Okay, we use different other techniques, but the articulator is a very good guide. Okay, because with the articulator you have simulations of what the jaw joint is. Is everybody familiar with this? I know you thought you'd never want to see it again, but that's it. We're going to see this a lot. This is going to be amazing. Here's what I want you to remember today, okay? Here's what I want you to remember today. This is a pin. This is an incisal pin, okay? Very interesting. If you're sitting there and you're relaxing and you're watching the TV show and you're just kind of taking it easy, and I say, stop right there, and I'm able to measure how much your mouth is open, and I go back and I wait till tomorrow and I say, stop right there, and I measure exactly how wide your mouth is open. Here you are at rest, sitting on the subway, and I say, stop right there, and I measure that, believe it or not, your mouth is going to almost be in almost the same position. When your mouth is at rest, it's kind of like in the same position. Maybe we're creatures of habit. Maybe the muscle tone sort of identifies where it feels comfortable at being. But the height that you're open is something that you are grown comfortable with. But we as dentists need to know that information, especially when we're getting ready to make teeth that are going to impinge on a person's opening. We need to know, hey, how are your jaws when you're just sitting there resting? If I make a set of teeth and a patient never can close their mouth, I don't know how comfortable they're going to sound or feel. So we need to know where their comfort level is, and that's what this incisal pin is. Sometimes we have patients that are clenchers and grinders and that are actually wearing their teeth down. Their bites become over-closed, and when we go to restore their dentition, we may want to open their bite up a little bit to try to get comfort for them. We can do that with this pin because this pin registers where the zero mark is, and if we want to open them up a little bit, we can open them up, or if we want to close them a little bit, we can close them. So I want you to understand what that pin is, and the beauty of this pin is that there's 5 black lines on the top of a dark black line, and there's 5 black lines below that black line, and that large, thicker black line is like your 0 point. So always make sure when you're working with the articulator is that this black line here is always at the very top of your articulator. Usually the distance that's halfway in between the maxilla and the mandible is, or let's call this the occlusal table, is recognized by this first pin here, this little line on this first pin. So just as we're going to go over the articulator a few more times, but for right now, just remember, always make sure that you have your pin in the 0 position. We're going to go over the whole part. We've talked about this before. And so now we're going to talk a little bit about the face bow, and then we're pretty much going to wrap it up. What the face bow is, the face bow has one function. The face bow is a device that's used to record the relationship of the temporomandibular joint as it relates to one structure, and that's the maxilla. The face bow is only for the maxilla. The face bow actually is used to reproduce the exact spatial relationship, bless you, of the maxilla to the condyles. The condyles, if you have a left one and a right one, that plane in a person, you're going to register that as it relates to the maxilla with the face bow. So what it does is it orients the plane of the maxilla or the maxillary arch to that plane of a line connecting the two condyles. Okay? So it's used to record the positional relationship of the maxillary arch to the condyles. Okay, let's go. We did this, I know already, and I hate to keep repeating myself, but this is the face bow. Okay, we have our little earpieces, and in your mannequin, you're going to use the earpieces, okay, to actually relate this bow, this face bow. Okay, come on. Oh. Okay, I can use that. There we go. That's the bow. Okay, and then the rest of the face bow is going to be used to transfer the relationship of this bow, which is the condyles, to the bottom part, which is connected to that famous wax rim that we made on our base plate. Okay, back to memorization. Okay, and we're closing down, but we're slowly closing down. It's going to be a little rough landing, so hang on. I want to explain this one little caveat, very important, because what we're desperately trying to find is we're trying to find repeatable landmarks. We're trying to find something that if our patient is with us today and we do a measurement, that the patient is going to have the same measurement next time we see them. So this is a great one here. This is called the ala tragus line. The ala tragus line is from the ala of the nose, which is the lower border of the nose, to the tragus of the ear, which is almost that little point at your ear. So one thing that's for sure, if a patient, they may forget their wallet, keys, and watches and everything else, but they're not going to forget their nose and their ear. They're always with them, all right? So it's something that I know that if my patient's in front of me, I can look at something that I know they've got with them. So that ala tragus line is a great line because I know I can always use it. I used to, and I got called out for it, all right? I used to go with my students in Rutgers for years. I used to take a pencil and I used to draw the line on their face. I mean, both sides. I mean, it looked like a Halloween convention. But the thing about it was that when you looked at that patient, that line was staring at you at all times. And what's nice about a line is that it's repeatable. So if I draw a line on the patient's face, and they come back next time, and I draw that same line again, and they come back next time, and I draw that same line again, all the dimensions that I took from the first time, I could get them back again because I drew that line. And so that's what the a la tragus line is for dentists that are making dentures, for dentists that are, or prosthodontists that are doing different kind of studies. There are also other lines. This Frankfurt plane is something that is used by orthodontists, also used, believe it or not, for veterinarians to determine like how old an animal is. There's certain kind of things that are used that we know we can measure. And so, but we use the a la tragus line in the clinic a lot of times. This is a face bow. This is a patient. This is the whole gear is put together. The little eyepiece that goes right under the lower border of the eye, and then our bow goes across from condyle to condyle, or from the inner ear to the inner ear. The patient is kind of helping us to stabilize it. Last year, we ran into a little bit of a problem because the D1s from last year were saying to me that we just can't get the concept of face bow. We just don't understand it. And I said to myself, I don't care what I do, the next freshman class that comes in, I'm going to figure out a way to make it so that it's ironclad and everybody will get it. And so I thought about it for a while. And if you think about it this way, if you have a line, and we're going to call this line, that line that I drew on the face, that a la tragus line, if we take that line and we draw a perpendicular from that line. If we draw a perpendicular from any line, if we draw a perpendicular from any line, and if we draw a perpendicular, here's our line, a la tragus line, going this way. If we draw a perpendicular from that line, something that sits in there at exactly a 90-degree angle, and then we go in and we take this bite fork, it's called a bite fork, and we attach it to that perpendicular line, we have now attached a plane, we've equated now a plane of occlusion to this line that we have, to this a la tragus line, because we've connected it perpendicularly. Okay? So if it hasn't put you to sleep yet, okay, you're good. But anyhow, think about it. We'll get to it again. That's the whole idea of the face bow. We do perpendicular lines, and perpendicular lines will get us to the plane. Once you've taken your face bow from your patient, we take it out of the patient's mouth. It now looks like this. We take our cast. Here's how it looks. The wax rim sits on that impression material that we have there. Here's the result. Okay, we're closing out now. Here's our face bow. We've taken the bow off, but we've put everything in the jig, which is what it's called, and we have now mounted our maxillary model. Okay? I'm going to be explaining this next time. The lectures are going to be one step ahead of what's happening in the lab, but this is the idea of the face bow. The face bow gets us to that point and that point only. The next thing we do is we have the lower bite rim. We incorporate the lower bite rim with the upper bite rim, and then we take that and we put the cast on top of that, and then after that we mount the cast. We turn the articulator upside down, mount the cast, and now we have a clean, smooth representation of the patient's jaw. I know I pushed a lot of information, okay? I know it. I don't expect you to know this at all at this point. The only thing that I hope is that you get excited about it. You don't have to know what you're doing. You just have to feel good about doing it. So I want you to take what we're doing and enjoy the ride, okay? Because there's a lot more coming. I wish I had the time, but Dr. Rubin, you would have been so proud. Excuse me one second, please. I have to talk to Dr. Rubin. He's like my favorite guy. I got to tell him. You would have been so proud of your class. You would have been so proud of your class like 2 lectures ago, and we had lab first, and then we had lecture, and then afterward I said, we're going back to the lab and everything, and someone raised their hand and they said, Dr. Hall, we're going to have lunch. And I had just, I get so excited, I forget about it. And then one of the students came up to me at the end of lecture, and he looked at me and said, Dr. Hall, I haven't eaten all day. I mean, it really felt bad. But I was happy because the class was leaving. I know you guys remember this. You guys remember you were walking out, and it was just one poor student, because I had asked any questions. She had her hand up, and the class was leaving, and she still sat there with her hand up. And I said, yes, what's your question? She just looked and she said, water. They're unbelievable. I hope you can stay excited. Yes, you had a question. You had a question. Going back.
Is that basically the final occlusion that the patient is going to have, or are we going to inside of it?
Okay, excellent question. This is a good question to sign off on. Okay, here we go. All right, here we go. I got to do this. I got to say this, right? I'm so glad you brought that up. Oh, listen. This is what I want you to go home with, okay? This is what I want you to go home with. When you see anything, when you see teeth, when you see a person's teeth, understand that what you're seeing is a reflection of light, okay? We're not just students, we're scientists. The reason that you could see something is because light bounces off of it and it hits the back of your eye and you see it. So you don't see teeth in the dark, you only see teeth in the light. What this is soon to be a reflection of teeth and light. So when you see this rim, a dentist sees more than just a rim. A dentist sees teeth in that rim. So that when I look at this, I could say to myself, by looking at this rim right here, this patient's teeth are going to be too long. Or this patient isn't going to be showing enough teeth. So what this actually is yes, this is what you're going to produce in the laboratory, and you're going to set teeth in there so that you could see that and then take that to your patient, try it in your patient's mouth, and see whether you need to make adjustments or anything of that nature. We're going to go over that in our next session. There's got to be some more questions. Does anybody want water or anything? Yes.
Next Thursday. Is it practical?
Next Thursday is right a week from today. Here's what I want. When, like I said before, we were badly affected by the way the holidays fell. So we don't have the ability to kind of get that back. Although, this is an institution whereby everyone is allowed to celebrate their holidays. Not only allowed, but encouraged. So I'm very proud of that. So the next practical in that vein, it's not going to be like a real hard slam practical. What I want to do, and I have to get permission from Dr. Freeman. He's kind of like he's in charge. I want to see you guys, I would like to see you make a wax shim on a maxilla. Fair enough? I mean, come on, it's a piece of cake. I mean, if you can't do that, we're hurting. A wax shim on a maxilla. So you're going to take wax and you're going to cut it. Now, of course, we have our way of identifying it so that nobody could do it at home. Okay, so don't think you say, get one of these slipping out. No, we're going to make sure that you've done it right there in lab. Okay, so don't even try it. We'll have a way to kind of mark it. Listen, don't think that they haven't tried this in the past. But I'm thinking about changing it from making an occlusal rim because you haven't gotten that far, and to making a shim. A shim, which is does everybody remember that shim that you had to do that you put to make the custom tray? At this point, that's what's on the agenda for the practical. And it shouldn't take you more than an hour. Any other questions? Yes, sir. Okay, did everybody hear that? And does anybody have the answer? Everybody, okay, the question is, Dr. Hall, hey, you know, we took the impression now. Now what do we do? Yeah, what do we do now, Dr. Hall? We did that. We go home. And we send it to the lab, and we let the lab work a little bit for us. So what we're going to do is we're going to collect your final impressions, okay? I'm going to personally sign off on all of them, okay? Every one of the final impressions that come out, that are turned in to go to the laboratory, I have to sign off them personally, or Dr. Rubens, or Dr. Swartz, or any other designated faculty that's with us. I'm sorry, what was that question? Sir?
Are we going to, like, should we just go in there and, let's say we're done with our final impression, should we just line up and start showing it to someone?
Right, but see, when I asked how many people were finished with their final impression, there's a lot that aren't. So for those of you that are, you just have to turn them in. Because the next thing that you're going to do is, unless you want to just, you could practice on making a wax rim. I mean, listen, please, listen. This is what you're going to be doing for the rest of your life. You shouldn't be told that you have to practice. Because if you don't practice, you're never going to get good. I've seen, just today, I've seen students that have come to me with preps, right? With preps, and I've said, listen, I think that it's a little rough. I think it's not deep enough on this side. And I've just said to them a few suggestions, and they've come back to me with some phenomenal looking stuff. You'd be surprised how great you're going to get when you just practice a little. So, but you guys have got to go home and, wash the car, do whatever you want to go. But those of you that really want to get good fast, you only do it by practicing, yeah.
From what I was made aware of, there's no more final impression material left.
We have an impression material. Okay, yes, that's a good point. We may have, here's for those that okay, as far as impression material is concerned, there's a lot of different impression materials out there. The kind of impression material that we were using for the final impression, that particular brand is out. I've learned how to manipulate it with another impression material that we have, and the faculty can help you as well. It's not as easy, but it's doable. So we have a substitute. Is it a substitute that I like? We have a substitute. Okay, so we can take impressions. One thing that's for sure, we don't have time to waste. I need everybody's final impression today before you go home. I don't care if once you have your final impression, I don't have to see you. But I need your impression because the laboratory has to deliver the models for you. And if they don't go out, if they don't get collected today, you won't be able to get your models next week. So it's incumbent on you to get your impressions in. Have a great day. See you in the lab. Because you're going to get signed out. Oh, you mean on that? No, I'm going to take care of that. I'll make sure that everyone's model's identified. Hey, buddy.
So why does it matter?